All right, well, thanks so much for joining us today for this webinar. This is the third webinar in our series DLT and Blockchain in the Real World. We created this series to highlight how public distributed ledgers and specifically Hedera Hashgraph are being used in production with new and existing applications to solve some real problems across various industries. And in our first and second webinar, which can be found on YouTube, we learned about the consumer privacy management company Mainnet and how they're using Hedera for data compliance, and then how the advertising platform AdStacks is using Hedera to fight fraud in the advertising industry. And in today's webinar, we're gonna be learning how Hedera is used by the companies Safe and Acoer in healthcare for data sharing and authenticity while retaining privacy. And we're looking forward to learning a lot more from them about that today. My name is Brady. I'm on the product marketing team at Hedera Hashgraph. And today we've got two folks from the leadership team at Acoer and Safe. Ken and Jim, why don't you guys introduce yourselves real quick?
I'm Ken Mayer, founder and CEO of Safe Health.
Yes, hi everyone. I'm Jim Nasr. I'm also founder and CEO at Acoer, but also working with Ken for a long time and acting CTO role at Safe.
Awesome. Thanks for that intro, guys. And we're looking forward to learning a bunch from you guys today. And since we have a number of new folks who are joining, we're going to do a quick overview at the beginning to talk about Hedera, Hedera's network services, and our governance model. And then I'll hand things over to Ken and Jim, who will share how they're using Hedera in production at Safe and Acoer. And they've got a little demo for us today as well, and a little bit of a deep dive into their architecture. We'll save time at the end for an FAQ for the webinar. So you'll notice there's an FAQ box on the bottom of the Zoom page. If you could drop your questions into the FAQ box, we'll try and address everyone's questions by the end of the webinar. We expect the webinar to go about 45 minutes to 1 hour. And with that, let's get started. So at a very high level, over the past 5 or 6 decades, the way that we've shared important data and transferred value has evolved. We went from documenting very important transactions and records on paper and notarizing them and mailing them around to inputting some of this important data on computers to make it faster and easier to keep record. And we interconnected those computers and used the web to improve access and make it easier for people to collaborate and transact in real time. And up until this point, we needed businesses and people to act as these trusted third-party intermediaries to facilitate trust for transactions and notarizing documents or performing audits. But now we're sort of entering this era of trust where we have these public blockchains and distributed ledger technologies that are creating programmatic trust for our data and our assets. And we can validate all of that mathematically, securely, and very efficiently, specifically using Hedera. So when Hedera was first conceived around 2 or 3 years ago, the team identified that in order to usher in mainstream adoption of this technology, it would need to meet 4 main requirements, and that was performance, security, stability, and governance. And so, you need to be able to transact quickly with certainty, and the network needs to support applications that are running at web scale today, like many applications are. You have to trust that the network's going to be attack resistant. The platform needs to be stable. With many other public blockchains, there's forking that's involved. And so you don't want to have application developers have to decide on which state their application is going to be in if there's a fork. And in terms of governance, fully decentralized governing body for code changes and decision making is very critical to the integrity of the network. And so related to performance and security, most of the applications that are running on Hedera today, including Acoer and Safe, they're leveraging a service called the Hedera Consensus Service. And this service essentially acts as a scalable and decentralized messaging bus. For Acoer, they're also using it for unique identifiers. And so, you can log important events to the ledger, you can make them verifiable, auditable, and available across multiple parties in real time. And the consensus source takes advantage of the native speeds and security and efficiency of the underlying consensus algorithm Hashgraph. And that's what makes Hedera very unique in the public distributed ledger space. And today specifically, we're going to be learning about data authenticity with Acoer and Safe, and the ability for them to log data in real time and make that accessible. All of that data being verifiable, and the transaction throughput can be incredibly high, especially due to the low cost nature and efficiency of Hashgraph. So because Hedera is a public network, it needs to be governed in a decentralized way. And the governing model chosen was based off of the Visa model. So there is going to be 39 leading global organizations that govern the Hedera network. They make decisions around the code base and other components, the treasury, things like that. They're found across 18 unique industries. They're required to run a mainnet node on the network. And it's decentralized across time as well. So folks who are on the governing body only have a 3-year maximum term with 2-term limits. And these are some of the folks that are on the governing council today, like Avery Dennison, LG, Google, a number of folks. You can find all of the governing council members on our website. For meeting minutes and the governing council agreement, you can visit hedera.com/council and learn a little bit more about that. And then finally, just a sort of complete overview of the Hedera ecosystem. We've got Hashgraph consensus underlying the network. There are the primary Hedera network services, the cryptocurrency service, and the consensus service sitting above, which are accessible to developers using various SDKs that we have. The code base for the Hedera network is governed by the Hedera Governing Council. And we've got applications like Acoer and Safe that we're going to be talking about today, using those services and running on top of the network. And so with that, I'm going to hand things over to Ken and Jim, and they're going to talk a little bit about their companies and applications.
Oops, muted, sorry. I'm Ken Mayer, founder and CEO of Safe Health. We're a partnership with Mayo Clinic on a mission to drive down the cost of low complexity care and commodity diagnostics at scale. We have been building a digital health and connected diagnostics platform that enables rapid implementation of custom digital health applications that can be set up, configured, white labeled for different, to service the different needs of specific populations or use cases. We started, and I'll share my screen here. We started about 2 years ago with a proof of concept called Safely, the Safe Sex app. It's been in the App Store for about a year and a half now. It has a couple 100,000 users, and it allows people to show their verified STD status on their phone. The platform connects in to the electronic health record systems through a number of methods. We're a Sequoia Project Care Quality Implementer and have a bidirectional data sharing agreement there. Sequoia is the largest national health information exchange. It was spun out of Epic. We also have direct API interfaces to all of the big EHRs through some middleware, and also bidirectional connectivity to Apple Health Kit, where users can either one-time import their health record or set it up to be, synchronized on an ongoing basis. When the COVID situation really started picking up steam in late February, we teamed up with United Health Group and Optum and Mayo Clinic, really looking at what it was going to take to get employees back to work. And from there, we developed the Health Check employee testing and health status verification solution. We now have some pretty big customers on there: Delta Airlines, Arizona State University. Just, I think last week, Jim told me we crossed the 1 million transaction mark. And what it does basically is automates the various work streams that companies and universities are now having to deal with to get their employees or students back to school or work. And things like ongoing testing, symptom checking, contact tracing, and we basically wrapped all of those things up into a sort of cohesive solution that allows them to kind of codify those protocols into automated work streams to make sort of managing this COVID response manageable. One of the things that we see as a next step is right now we're anchoring this privacy protecting health status verification with your testing records or having met the sort of interval timing on a symptom checker protocol, right? Where you have to take the symptom checker every day. And if you don't, when you go to scan in with your digital passport, maybe I'll jump down there, you'd be denied access. And we really thought long and hard about how, we create a scenario that allows companies to, basically utilize health information for access control, but to do it in such a way where the individual's we're not sacrificing individual privacy. So what we came up with is this idea of this QR code that abstracts a national health ID that we generate when users are onboarded onto the system, and which is connected to their health record. So when they go to scan in, whether it's a human or it's connected now, we're working to connect it into access control systems. They use their fob key and they're denied access. The person scanning them in doesn't get the reason why, right? It could be that they just haven't taken their symptom checker by 9 a.m. that morning, or that they haven't, they're supposed to be tested every week and it's been 8 days, or that they have an active COVID infection, right? So hence the sort of privacy protecting health status verification concept. And actually, to be frank, we were working on a project developing a system for the porn industry to sort of extend their pass system that was implemented in the 90s after there was an HIV outbreak on some of those productions. And they basically, the talent goes in, the producer has to check them by putting in the talent code into a web page, and it says ready for work, not ready for work, just binary. So to be honest, we kind of stole the idea from that and implemented it here. So, while it's, kind of neat and it's a first step to kind of get the ball rolling to anchor this, access control, health status access control with testing records, it's really not effective. I mean, where this really comes into play and can truly be used to get, billions of people back to life is once a vaccination comes out. We had been working with Mayo Clinic, even prior to our strategic partnership, on a project codenamed Vaxi, which is a vaccination management solution. Our platform is tied in to not only these HIEs and EHRs, but also we are steaming towards having all 50 state vaccination registries connected to the platform as well. So the idea is once there is a vaccination, there's going to be, a lot of debate, obviously, around people that take it, that don't take it. But in our discussions with Delta and other large businesses, some of the professional sporting leagues, that really is going to be the sort of determining factor of getting people back at mass, right? So being able to take our binary, available for access, not available for access feed, and to be able to plug that into ticketing systems, to fob key systems and access control, and even airline ticketing systems is going to be a very powerful tool. And something we're really inspired to do is, starting with public schools. So through our board member, Dr. John Halamka, who's president of the platform at Mayo Clinic, we've been socializing the idea with the Department of Education and HHS. And we're really, excited about, the possibilities of that. So just to kind of run through, the question, how do you verify the vaccination status of, the world population everywhere at all times? You meaning if, you want to go into that Lakers game or get into Coachella or even an AMC movie, or your office or school, you know, the way to do it is really these ubiquitous phones, you know, and tying it in with a digital platform that has, you know, a real immutable record connected into a platform that has access to those data sources. So kind of jumping around a little here. So, you know, we're starting with health check. It's the way to sort of proliferate it. Again, we've got some big enterprise customers. We now just partnered with the largest buying co-op for universities that have about 5,000 members, basically every college and university in the US. We also just partnered with the largest employee benefits marketplace, who's starting to push this out, starting with employers and schools. Basically the solution, just to give you some highlights, it's a white label mobile app. And you know what I'll do here is pull up my sharing and see. Share my desktop here. It's a multi-tenant platform. It's the microservices architecture running in AWS Cloud. Jim will get into all the specifics on the tech. But basically every tenant gets their own dashboard. This is in staging, so it's all dummy data. This is an example of what Mayo's employees would see, or the administrators of those Mayo employees from either their health department or HR. They have population level information, state level, and then different reports about how adherence to things like the Daily Symptom Checker and the testing protocol. You've got basically a profile for, you know, for the different users. You have different roles that can be set. Health administrator has access to everything in the admin console, and an executive admin basically has the PHI scrubbed from the environment. You can see here the national health ID that's generated that Jim will get into in a minute. And then you've got this full kind of customizable, you know, demographic information where you can add custom metadata fields, create employee tiers or user segments. You have an audit trail, which is one of the things that, you know, most of these companies are really looking for more than an infectious disease mitigation strategy is a liability mitigation strategy. So to have verification that the user went through and did their daily symptom checker, you know, through the app, and you can see here, this is Mayo's version of the app. And this questionnaire, what we call a virtual consult, is basically built on what we call an assisted care automation engine, which basically allows us to codify the protocols for in-person doctor visits around low complexity use cases. So this here is based on the CDC guidelines for back to work. It's asynchronous, so if I didn't report having a fever, it wouldn't have asked me this next question. This is all kind of interacting right now through the rules engine. And basically the companies mainly are requiring that the employees take this every day. Part of the CDC guidelines is that you do an exam with your employees. So this just basically automates that work stream into something that's manageable. And it also creates this audit trail, as you see there. So then at the end of the virtual consult, it comes with a diagnostic or a conditional outcome. This is in staging, so I guess they haven't set it up yet. With Delta, what this would read if I reported symptoms is, you may have an active COVID-19 infection, please self-quarantine, and a test kit is on the way. And it actually automatically then triggers a order for our DC, our distribution center, to mail out a home collection PCR kit. When the results come back, we have data integrations and partnerships with Quest and LabCorp, Mayo Clinic labs, several other small labs that you know, automate the process of then returning the results, either through Fire interface or, in the case of Quest and LabCorp, an HL7 interface. There's a lot of other customizations I won't take you through, but you can configure resources, FAQ. You also have a direct messenger that's built in that uses direct protocols so that the employer or university has a way to sort of communicate with personal health information with the end users. with the admin console, just like I said that, you know, if the conditional response was to get tested or the protocol was for me to get tested, you know, say every month or every week, you know, that testing history each time I was tested would appear here. And if I was a health admin, which I am, I can come in here and see additional info that's made available through there. There's a high level of customization that can be done here with different settings, where you can come in and set like the frequency of the symptom checker, reminders, the different tests that are used, how it's billed. We have a connection into Change Health, so we can handle the full claims and billing that starts with an eligibility check, and then you know, patient responsibility, and then handles the whole claims workflow there. So one thing I'm going to kind of quickly show you is how this all started was Safely, which you can see is you know, basically the same exact app built on the platform, slightly different UI, definitely different picture. And here you have multiple options where you can get tested. In this case, it associates a provider who's licensed in the state where the user is with this virtual consult. And this one, you know, is set up using the assisted care automation engine to basically codify or replicate a doctor visit if somebody goes in asking for an STD test. One of the things that we were really inspired by, you know, on our mission to reduce the cost of low complexity care at scale was removing or reducing the cost for consumers to access covered diagnostics, and specifically around these ultra common conditions or care scenarios. There's ultimately about 20 low complexity care scenarios that represent over $1 trillion a year in spending, and all 20 of them, you know, UTIs, which are the most common office visit, STDs, strep throat, influenza, are all priced at 3 to 5 times what they could or should cost. And a big part of that is the way that diagnostics are actually done, and the fact that you, unlike most products and services on the planet, need permission from somebody to access them, or at least if your insurance is going to cover it. So you can see here, it brings up a separate conditional response where Dr. Fife is basically prescribing this 6-panel test. We're then connected into the scheduling systems with Quest and LabCorp, which may load with my slow internet. You can see all these that are around me here in Los Angeles. Can go to one. We're tied in actually with their scheduling systems. Actually an appointment later today, all right. I'll take it. I can use my insurance, can scan the card, or we basically have all of the insurers and plans configured into the system, or I can just pay cash. And you can see there we have things like coupon code charges. So one of the things that I'm really excited about that we've been collaborating with Columbia University and a scientist named Sam Sia is the idea of connected diagnostics. There's been, over the last 10 years, a new kind of form of tests with these, or an expansion in what's being done with lateral flow technology. There's now lateral flow tests for about, there's now lateral flow tests for about 30 different things that are CLIA waived. You know, things again like strep throat, HIV. There's now several that are getting EUA approval for COVID rapid antibody tests. And now there was just a big announcement that Abbott has a rapid antigen test. So we have a technology that basically scans, you know, allows you to use your telephone to scan, you know, the test cassettes. So you get walked through a clinician-directed virtual consult. It leads to a requisition for the test, making it coverable by the ordering physician associated with that virtual consult. And then the user just gets taken through the collection process, takes a picture of the cassette, the result when the timer's up, It sends it to our scan assessment engine that we co-developed with Columbia and returns the result. From there, the ordering physician can then action a prescription or additional confirmatory diagnostics. And that was really what led us to Hedera in the first place. Prior to even this identity scenario, it was really around the idea of, you know, as we pull these tests out of the laboratory, and in order to handle them, you know, at scale, where we're associating providers through a crowdsourced telehealth system with these home diagnostic transactions, we really do need an immutable record, you know, of those. So that was originally, you know, and having those conversations with Jim even prior to Health Check, you know, what really got us excited about Hedera and the Consensus Service to be able to, you know, really log all of those transactions in the ledger so that they could always be matched back to, and then, you know, obviously not putting the data itself, but links to the FHIR resources where that information was stored. You know, just to kind of give you an idea, the picture here of the connected diagnostics, we have it now working with a BTNX rapid antibody test, and we're now working with Abbott to configure their new platform for the COVID antigen card. And for us, we're agnostic to the digital or the diagnostic endpoints that are on the system. So we're actually partnering with, you know, over a dozen now different diagnostic manufacturers, ranging from microfluidic real-time molecular tests like Q Health to a number of different lateral flow manufacturers. And again, this diagnostics, it's all part of this digital workflow. So whether the test is booked at you know, a patient service center on a lab-based test, it's done with a home testing kit, or it's done with a lateral flow connected diagnostics enabled test, or even an endpoint like Q Health with, you know, real-time molecular testing. All of it sort of flows in to this EHR. It's abstracted by the National Health ID, which is represented by this QR code and can be used for you know, health status verification and access control. So with all that, I'm going to pass it over to Jim to kind of fill you guys in on how he made all of this crazy ideas work in reality.
All right, thank you, Ken. That was excellent. Would you mind? Let me see. Can I take over the sharing of the screen here? Do you need pass control? Okay, here we go.
I think I just passed. I don't have control, but I turned mine off.
All right, cool. That's all right. Let me just share my screen real quick. And can somebody confirm if you can see my screen?
Yep. Nope. We see you on your shared screen.
Oh, but not the actual screen?
No, your full screen. It's kind of cool. You got your small one up top and then the full screen, Jim.
Okay, that's not good. That is not good. Let me see. Why is it not sharing my screen correctly?
Probably just have to select PowerPoint as the.
Yeah, let me do that. All right. Apologies. For some reason, my system has decided this is the right time to be very slow. So I was trying to fix it as you were talking, Cam, but I didn't want to get off the call. So can you guys see my screen now?
There we go. Yep.
All right, cool. Okie dokie. I apologize if it's a little bit slow, but yeah, I was doing some database queries and things, and I think I've maxed out a lot of my resources, but nonetheless. So, so what Ken described, and hopefully it was evident to all of you guys on this webinar, is really an incredible vision. It's a tremendous, it's just a tremendous innovation and very, very ambitious and many, many moving pieces to it. So really my job as really the chief architect or acting CTO is really, if you like, a town planner. I need to be able to, you know, if you take this analogy, be able to design the roadways, you know, how the different zip codes, different neighborhoods are connected to each other in a way that allows us to continue to build up the town, but also to be able to discreetly work on any one neighborhood without impacting the other ones. That's, just as a metaphor. But really, it's very much this idea of building modularized software using microservices and exposing that technology, exposing the functions with application programming interfaces, and then within the deployment phase, deploying and using containers and Kubernetes and technologies like this to manage the deployment. So that's really what we have built and continue to build. I'm not going to go through this conceptual architecture in detail. I think all I really want you to take away from this slide is that we have many moving pieces. If you like, those boxes are the zip codes, and the line items within them are the neighborhoods, right? And of course, there's many, if you like, many houses and stores and things within those neighborhoods. So that's really the world that we live in. And our challenge is to make sure that, well, first and foremost, that everything is safe, secure, performing, and reliable. That's number one, sacrosanct, right, above everything else. And that's what Ken obviously always, kind of brings to the forefront. Because we are a HIPAA compliant provider. We are dealing with patient data. That is by far the most important thing. But that aside, really is about how do we make this innovation happen in a way where we have a very large and distributed decentralized engineering team. I think last count, somewhere over 70 engineers around the world. How do we make this work such that we're efficient, we can work autonomously and independently, yet within essentially one signature pattern, right? Because that's the challenge, right? We cannot just do our own thing and expect to have this very convoluted, complex, and featureful technology all work. So that's really what we're doing. Again, I'm happy maybe if there are specific questions later on to get into any specific details. One thing I would like to mention is, as you can see on the right-hand side of the screen, is we do have a lot of integrations as well for many different purposes and with many different partners, including Hedera. And this goes back to my point earlier about using APIs and how important that is. As much as we all love blockchain, and of course we're here to talk about, how we're using Hedera and real-time DLT services, really the secret sauce for building this kind of a solution is to be interoperable. It's to, by design, be open, have open technologies that can be that can interoperate, and we've really tried to do that. And I have a slide a little bit later on that basically talks through that. Okay, moving on. So this is, again, I'm not going to go through all the details of our architecture, but it is a very modern architecture. We do use cloud services where we have Azure and AWS and some redundancy between the two. We do use as much as we think it makes sense some Cloud OS services. Our philosophy generally is to build technology that is as decoupled from infrastructure and components as possible. In some cases, and those of you guys who are technology architects will notice, the business demands and budget demands and constraints, just basic kind of constraints theory limits how kind of ideological it can be. However, we have a roadmap, like I mentioned, we have a signature pattern. So we know as time goes on how to evolve, but nonetheless, we're also realistic in what it takes to actually get things done in the short term, because none of us has infinite time. So that's really kind of what we have. Again, I'm not going to get into all of the kind of components, just to say that it's really built kind of from the ground up to be modularized as much as possible and exposed, using the APIs and deployed with containers. Okay, moving on. So this may be the areas that are really interesting to most of you folks, with a Hedera background or some Hedera interests. So we are big fans of Hedera, have been for a number of years. My company, Acoer, has been a Hedera partner for, I think, since the beginning, really. Even in the days when I was at the CDC and Ken and I had just started, our kind of friendship and working together, and way back in that time, we were interested in what Swirls was doing and where what seemed like amazing technology could go. So the advent of Hedera a couple of years ago as a public DLT was really exciting, because it, again, ultimately, this is what I believe, it's what Ken believes. that we, in order for us to innovate in healthcare, we need to be thinking real time. We need to be thinking about technologies that are really consumer oriented. Hence the great job that that we have done, and the vision Ken has with the mobile apps, this real-time services, this lowering of costs by providing a usable experience. We very much believe in this, and I think that was one of the reasons that Ken and I got together early this year to figure out how we could take our our technical experience and expertise and marry it with what Ken already had in place, and really try and grow this vision into a reality. So all to say, really this idea of transaction authenticity is one that we're really kind of keen on. And what we're doing, what I'm demonstrating here, again, is at a glance, it's not all of the details. It's this idea that, we are able to take medical endpoints, and I give you a specific example. When Ken was going through the demo on the app, the development app that he was showing, clicking through the different questions of the CDC protocol for COVID, at the end, he came up with what we call a medical endpoint. The endpoint was you're symptomatic, and it was a dummy placeholder for a message, but nonetheless, the actual medical endpoint was that, he was symptomatic based on the results of the questions. It was providing an R algorithm. So that particular symptomatic diagnosis, there is an encrypted reference of that on Hedera. We created that in real time. And this flow essentially shows how we've done it. I'm not going to go through all of the details, but essentially it shows that the process, as Ken demonstrated in real time, to go through the questionnaire, the resultant medical endpoint, the diagnosis, if you like, and then what we do thereafter to take that specific transaction and record that transaction on Hedera using our Hashgraph Data Stamping service. So, and then later on, if there's a regulator or if there's public health reporting or any other reason for us to go back and essentially try and verify the authenticity of that particular transaction or anything like it, we're able to do so because we can show that the chain of custody of that transaction is not broken, that there's an immutable transaction on Hedera that proves that with the right and specific data stamps. So again, not to get too detailed about it, but this is really core to the way we think about this idea that Ken had described, which is real-time transactions and really proactively proving, having a proofing service that shows the critical elements of our application and our technology actually working in a way where the data and the transaction can be relied on. And really, in my parlance, we're imputing computational trust. That's the whole reason why we're trying to do this. So you don't have to trust Ken or myself because we're good people, or because we're using some giant intermediary as a trust mechanism. You can trust the cryptography and Hedera's infrastructure. All right, moving on. So Ken also mentioned that we generate a unique ID. We call it the National Health ID. Essentially what this is an ID that we use Hedera Consensus Service for. We have an algorithm, and for obvious reasons, I have not disclosed the specifics of the algorithm, but that algorithm, whenever a user is created, the algorithm essentially calls HCS or runs the algorithm, and we create this number, this unique number using HCS, right? And then that number, though with no reference back to the patient, of course, is available for interrogation on the public DLT. And this is really to prove that the number is unique, because we have a big vision, and Ken intimated about this, to really do patient matching, to really take this concept of a unique ID and actually make it unique across different data sources. As most of you guys do know, perhaps the single biggest issue in healthcare is siloed data. Jim Nasr is on like 17 different health systems and possibly 16, 17, 18 different variations, even within the same system, of my record, different spellings, the different IDs and things like this. And ultimately, this is something that can be resolved, though obviously not just by technology. There's policy and there's many other things that are involved. but really mass adoption is the way you could accelerate this kind of a concept for policy and legal provisions to catch up. All to say, this idea of taking that national health ID and really associating it across different siloed data sources that really are, again, just reflecting my record, but are not necessarily, you couldn't uniquely identify me directly from. So moving on, this is, again, we're doing a lot of really, what I would say, kind of on the edge design and pretty interesting machine learning and entity resolution and other experiments. What it takes for us to take this national health ID and really do cross-linking and matching. So and again, this is illustrative of the work we're doing, but ultimately on the left-hand side of this picture are the many different data sources with which we are interacting with or could potentially interact with, including network of networks, feeds, and things like this. So just thinking ahead, on the right-hand side is really our campus and our technologies and our stack and how we're essentially using our data lake and our entity resolution technology and our own patient data records and really trying to, in as interoperable way as possible and in as kind of real-time way as possible, do this kind of a cross-linking and then ultimately impute this national health ID or assert it and insert it across different data sources. As they say, watch this space, that there's a lot happening here. We're excited by it, but it's very ambitious and it certainly is one of those things where we think if we can do this and do it well, that this has a real material impact across the industry. Moving on, I did mention a little bit earlier that we have a real commitment to open standards. We actively really think about this. We push our development team to build code in this way. We really just in many ways insist on even at the lowest level of nomenclature and naming convention and how we do our Swaggerized API documentation to be very, very consistent and very, very kind of adamant on doing it in this way. And reason being is that we're building a very large system. If we're unable to isolate functions, unable to isolate fault, unable to build in parallel, we will never reach our goal. So that's really that's part of it. On the right-hand side of this picture, you see the predominant technologies, healthcare technologies and standards that we're working with. And again, our direction is largely FHIR, which is a fast healthcare interoperability resources standard, which is really a deviation or variation of RESTful API. So very much proven, has been around for 10 years, and very, very importantly, is now adopted by the Cures Act, the 21st Century Cures Act, which is law as of January 1st, 2021. That really basically stipulates that EHRs, EMRs, electronic health record systems, they need to support this FHIR as a way for allowing standardized or standard protocol-based patient data access. It's a very, very important concept. It's one that I am very hopeful is going to propel all of us as individuals and patients into a much more modern and freer way of getting to our patient information, and also, frankly, allow our agents, entities such as Safe Health, to be able to help us get to that data and then possibly cross-pollinate or cross-reference our data to help us make better decisions, cheaper decisions in a more comprehensive way. Ken also mentioned the Apple Toolkit, Acoer project, where we're members of those and leverage those. And again, our services are not just about, kind of diagnostics and kind of COVID or any one kind of just one or two particular areas. We're really trying to kind of at large build a system that they can deal with very large and a large number of low complexity health conditions. So therein, preventive healthcare and other kinds of interactions and exchanges is really important to us. Moving on. All right, so this is a little bit more technical. I'm not going to go through it in a whole lot of detail, but since this is a Hedera conversation, and I know most of you guys are familiar with our proofing or data stamping services, and you're possibly familiar with some other proofing services, including Hedera's own kind of state services. this is just to show what we do, right? We have a serverless kind of architecture that we use, including a serverless database with Fauna. And then ultimately, what we're really trying to do is expose the functionality as APIs and really abstract out all of the backend infrastructure. So any one of us, whether it's our team at Safe or whether it's other clients or independent developers, can use those APIs without having to worry about scaling, without having to worry about infrastructure, deployment of servers, none of that, right? Because all that really creates more of a distraction and complexity. And we really want you to get value from the service and not have to worry about all of the configuration and all of the scaling and all the other things that then, we as engineers have already thought through. This next and last slide is really just a high level flow of our data stamping service. Again, it's pretty technical, but really all we do is we're generating a JWT, a JSON web token, and then we're essentially passing it through the different layers of the infrastructure. And then ultimately, whether it's through our own proofing services with barcodes or other artifacts that we're working on, or whether it's through some other third-party proofing services, we're able to prove that transaction. And then certainly, as I mentioned earlier, we're using this already in production. I think as of today, I was just looking it up. I think we've had over, I want to say 2.7 million transactions and this on the Hedera mainnet. I was just projecting from yesterday, because yesterday was just over 2.6 million, and the rate of growth has been very, very significant. So, and then Ken mentioned this in his conversation as well. We've had well over 1 million transactions just from Safe alone. So really we take this very seriously. We're doing this in production, and ultimately, like my belief, is, and I think Ken really believes in this as well, that it's time for us to use DLT for real, and not just yet another, private blockchain proof of concept with 3 nodes. I mean, I think we have proven that serves a purpose, but that doesn't necessarily serve many purposes, or doesn't necessarily provide transparency or this kind of scale that we're trying to get to. And then therein the opportunity to be able to marry the 2 concepts, perhaps using Hedera Consensus Service. Okay, I think that's all I have to cover on my end. Hopefully I did not bore you guys too much or run over time. Brady, I guess it's back to you now.
Thanks so much, guys. Really appreciate that. Lots of details there, especially for folks who are building applications right now. That the architecture diagrams and everything were awesome. So it looks like we've got a bunch of questions that came in through the Q&A box. And everybody, if you have questions about the presentation for Ken, Jim, or myself, be sure to drop those into the Q&A section. So we can just start going through these one by one. This first question is about Hedera specifically. It says, in the future, would a high price per hbar affect the business model? And they're referring to the volatility right now that's happening on Ethereum, specifically around DeFi. And so the fees on Hedera are actually flat rate fees that are set by the council. They're paid in hbar, but they're set in US dollars. And so network activity isn't going to have a direct impact on the cost of transacting. It's going to be a flat rate. There's actually a fee calculator that's very detailed at hedera.com/fees, and you can go there and based on your API call and different parameters can determine how much it might cost for you to run an application on Hedera.
Brady, if you don't mind, if I could add to this, because this is a question that I often get asked, in various contexts, which is, why Hedera, right? I did mention real time and scale and things like this, but honestly, just being practical, we have this vision that Ken has shared, I have shared separately, this idea of using DLT for real and at scale, but it has to be economically viable, right? Because if it's not economically viable, we're just in wishful thinking land, right? And I think this is one of the things that people who are not very familiar with I guess the range of blockchain protocols and services don't necessarily appreciate that, if we're trying to really make a difference, if we're trying to build this kind of like real-time transparency and data authenticity, or at least proof of it, you have to have a protocol that is economically viable, right? And having kind of highly volatile native cryptocurrencies, or having to spend a lot of gas for simple transaction data provenance, it's just never going to work because you cannot financially justify it. So this is, I mean, we look at the holistic picture, but certainly this is a very important concept.
Excellent. Yeah, great points there. And then this person is asking when they expect to go live on the main net. I think you had answered that previously, but do you want to dive into sort of what some of those metrics have looked like, what kind of activity you guys are seeing?
Yeah, so I mean, the good news here is we are live on the mainnet, right? This is all live, right? You can go to our ledger and you can look up transactions and things that we've done, for Safe. So it's been live. I want to say, from starting small, probably in June-ish time frame to now, where we're really, I mean, we have and can elaborate on the number of users that we have on the Safe platform, but let's put it this way: it's well over 6 figures. And the number of transactions I already mentioned is well over 1 million. And then our own, the non-Safe transactions we've had, like I mentioned, I think close to 3 million transactions in production on the mainnet being used for real.
Excellent. This person's asking, how do you retain privacy? So for example, a user who is now infected has only come into contact with one other person.
Yeah. So there's a couple of answers on this one. I'm going to let Ken kind of talk about the system, and if necessary, I'll talk about, well, I mean, I'll just mention that obviously on the DLT, we do not have any kind of patient-related information, right? So therein, there is not a direct, there is no way to kind of go back from the DLT information back into our private system. But Ken, do you want to talk about kind of our privacy kind of controls?
Yeah, so, the next step really is to create an index of where the individual's patient records are. And, one of the biggest problems is we were, working on trying to connect into these electronic health record systems at first to get people's recent STD test records in a complete sort of tamper-proof digital workflow. We were thrown headfirst into this sort of soup of patient interoperability issues. And over the last, I guess, 4 years, as we've been working with it, and things like Sequoia project have been evolving, and more of the EHRs have been, either adopting FHIR or making it easier to interact with them using FHIR. One of the biggest remaining problems is patient matching. And there's companies like SureScripts that does, e-prescriptions, and is pretty much the sort of industry standard platform for that, that does some of it. But there's really not a unique identifier that transcends health system or even EHR. And that's kind of what we're inspired to create unofficially. Now, this has been a third rail, issue for the past, 2 decades, where Congress has, appropriated funds for a national patient locator for HHS. They've repealed those funds. They've, told them they should find money to do it. They forbid them to do it. So, it's been a real hot button issue, and it's something that I think the private sector really needs to step up and do. And we see this COVID situation as sort of a unique, sort of catalyzing event, or kind of almost a Pearl Harbor type moment that, can be leveraged to sort of push this, into reality. And with the first objective really being anchoring this privacy protecting health status verification connected to your vaccination records, but you're going to have, millions of people, tens of millions of people that aren't going to want to take the vaccine. And that's cool. And it's going to cause a lot of debate, maybe even riots. But, big companies like Delta or, the NFL have to decide, how do we protect our patrons? How do we protect ourselves from getting sued? And how do we get people en masse back using our products and services? And it's very highly likely that they're going to utilize vaccination status as one of those, determining factors of who they let in. But then again, you also want to allow, Ed Baskin wants to allow people to get on Delta airplanes that might not want to take the vaccine or give it to their kids. So we've come up with a scenario whereby you could set up these on-site testing locations, leveraging this new real-time molecular testing technology like Q Health or Abbott ID Now version 2 that can detect, very, very early stage infections, pre-symptomatic infections. And they're already down to like 15 minutes, probably by this time next year, once the vaccination is really, available to the masses. Those tests will be down to 5-10 minutes and cost, $10-15. So, you'll just decide, and again, your personal decision as an American, hey, I want to fly to go see my mom on Delta. I don't want to take the vaccine. So I'm willing to get there an hour early and spend the $50-60 to do an on-site clean area test. Same thing if I want to go to that Lakers game. I'll just get there a little early, wait in line, pay my $50 or be a VIP, pay 120 and get, brought up like Disneyland to the front of the line. So, there is no perfect solution, I think, to this, but it's something that we do need to sort of deal with as a society. And from a commercial standpoint, you could imagine, charging 20, 30, 50 cents per scan enabled with our API into Ticketmaster, into the NFL's ticketing system or AMC's ticketing system. That's a negligible cost to the actual, event producer. But it starts getting pretty large, and we'd want to obviously track all of those transactions in Hedera so we can make sure, like mechanical licenses on music, that we were able to collect on those. So there's some interesting things that we haven't got into yet quite on how we're handling the financial transactions, but we do think there's some exciting stuff we can collaborate with Hedera on that front too. On the privacy side, just to sort of get back and address that is, we really see looking at following a model that was used by Jeff Jonas, who's now at Senzing. He used to be, head of identity at IBM. And they did a project with Pew Charitable Trust called ERIC, the ERIC project, where they went in and registered like 40 million unregistered voters across, I think, 20 or more states by now. And they did this sort of, and Jim can get, more into the nitty gritty of how it's done, but this sort of double hashing, anonymous linking of records. And that allowed the states, or, the states allowed them then using that method to basically tie in with the driver's license records and the state's, voter registration records, right? So we're looking at doing something very similar, but with student record systems and the vaccination registries. And again, the ledger would only have basically a link or an index to where these records were, where they'd be stored in, an encrypted state, and there'd be, sort of the magic that Jim and Hedera work out to make sure that nobody that shouldn't have access to them gets access to them.
Related to health records, this person's requesting, how do you verify that the person using the application is actually the person whose health records are being checked? So basically, like, how is the identity verification handled?
Yeah, so that was a really important, part of it. And we really dug deep into that around our proof of concept with Safely. We're importing people's vaccination records. We don't want to allow some paparazzi that knows a lot about Brad Pitt to get his, recent STD tests, right? And, when we started, almost 4 years ago now, KBA, knowledge-based authentication, is how it's done. I actually went and had like a minor identity fraud thing, and I had to log into Experian or create an Experian account that my assistant did. And we're sitting at the table and she's asking me all these questions, and I'm like, this is so stupid. I mean, this information is readily available with all the systems that have been hacked over the last, 5 years. Someone that really wanted to find the answers to those questions for me could find them. So that's, become pretty antiquated. The answer to the question is when it's a consumer app that's downloadable and people are actually initiating the sign up on, or if the users weren't onboarded through a very trusted source that have already verified their identity. So for instance, with Delta, we're basically comfortable with assuming that when they tell us this is the identity of this person, that as a Fortune 100 company, they vetted them and that they're properly onboarding them. So again, this sort of unplanned enterprise solution model around, this sort of back to work, back to school has kind of helped in that area. with Safely, what we do, and now with the consumer version of Health Check, is we have a third-party mechanism in the app where you scan your driver's license. You actually take a video of it, and then you take a selfie video. It gets sent to a cloud service. They match that ID against the database that they have of all government-issued IDs, which get into the nitty-gritty of the holograms that are on them. They use video, so there's a bunch of images of it, not just one, which could be more easily faked. And the same thing with the video. They then use image recognition to compare your photo on your government-issued ID with your personal photo. They also do some other checks, like going out using a service similar to Full Contact, which is an API that's indexed everything on you, right? So it can then be a score is generated, based on, okay, does your ID match? And now, can we match that with maybe some credit card or credit record, publicly available records with your Instagram, your Facebook, your LinkedIn, and it comes back with a score. So depending on the level of access to the records that we're providing, we toggle what that score should be.
Cool. And could you clarify, did you say that this is going to be available in 50 states, or is there sort of like international ambitions for this application?
Yeah, we definitely want to take it international. And I mean, that's a big push for Mayo is sort of taking their brand and, leadership in the healthcare space, outside the US. They just opened a $1 billion medical center in partnership with a university in London. There in London, they're opening up another one in Dubai, and there's some in the works for China too. So we've been working with them and Oxford and the NHS, Lord Pryor there, who runs NHS, around taking it out in the UK, and are starting to have some conversations about the EU and also Japan. But yeah, we do. It adds some additional, sort of complexity, and the good thing is that FHIR has proliferated globally, and in fact was adopted, even earlier, a lot of places outside of the US.
And then this question is probably for Ken. How much batching is going to occur with respect to data streams? And are there regulatory requirements to keep an individual's data separate from everyone else's, or can data be lumped together and sort of, they're referencing the ad stacks use case where everything is sort of in a singular place?
Yeah, so we're not really taking the records in most of the cases and storing them, right? So each individual has their own, individual sort of record in the system. In the case of bigger employers that are using the enterprise model, they have their own, environment or cluster that they're running on. We're more indexing where the records are. I mean, that's the beauty of FHIR, is it really is using this sort of document-based infrastructure to where they're just basically URLs, to these FHIR resources. So I think the new way of kind of doing this isn't as much, pulling all the data in where we're storing it on this big massive database. It's more just indexing of where those records reside, and then having the data sharing agreements with those entities to allow for a fluid, access to them more than grabbing them. I use the word import just because I think of it that way, but we're not really importing the record as much as indexing where it is.
Yeah, makes sense. Are there developer docs for the Acoer data stamping service?
Yes, yes, we do. We have swaggerized our APIs just like we've done at Safe. So yeah, we have this off of our website, but happy to provide it offline.
Awesome. And then this question is, and we can provide that to everybody at the end of the webinar, also in the follow-up email link to the Acoer documentation, if you'd like to start using it. This question is around State Proof Alpha. So that was just released yesterday. It's very brand new, so there may not be a full answer for this yet, but this person's curious about how you might use state proofs in the future.
Yeah, it's a really good question, Brady, because I mean, obviously, well, not obviously, but for most of us in the Hedera space, we've known about state proofs for a long time. I mean, like easily a year and a half, though it's not been available. So with the alpha, I was just actually thinking about this last night, right? We think that there's some use cases, and we have some non-healthcare clients that we work with and are working with, and in particular some journalists that we've worked with, started working with at the beginning of the year. In fact, ironically, it was about coronavirus misinformation, and then of course we got very busy with Ken and working on SAFE. But this idea of, as example, proof of authorship of an article or an image, right? That's something where, like, to me, the state proof may well work in like either without or, at least from our perspective, with our data stamping service, right? And you wouldn't necessarily use it, in every case. You have to have some specific use cases. But back to your question about alpha. So we still need to experiment with it because it was just announced yesterday. So my question, at least in my mind is, so right now you're essentially you're getting a transaction file that contains possibly thousands of records. They're going to have to sift through that, and so the question is really, how efficient is that going to be for a particular use case, particularly if that use case is real time, how are we going to make it usable, right? So and let me take a step back. One of our philosophies at Acoer with Hedera and DLT in general is to abstract out as much as possible. So not have users worry about wallets and keys and things like this. So we abstract that, which means we take on the risk. But as a result, the experience for the user is different. I think it's a lot simpler and to me scales better from a usability perspective. But then the question is, can we do the same thing here? And if so, what would it look like? Now, the other question for state proofs, and this is a question I think has been out there for a while, is really what is the economic viability of it at scale, right? And I'm not really sure if that question is easy to answer right now, or if the information is really there. I think we kind of have to really dive into a use case at a time. At least in my mind, and maybe it's just because I'm not that informed yet about it, I don't know if there is a black and white, scenario for it. I think it's a little bit more of a gradient. But all to say, we're excited. We definitely think it's useful. I just think, personally speaking, that we have to be pretty specific about the use case and where and how often it's used, right? Also, honestly, Brady, I think, and this is perhaps more of a Hedera thing for people like yourself, Mance, and Lehman and other people, is really educating the market on, so what? Okay, it's great, but what is the so what? I'm not sure if people outside of a small little category of techno geeks really get it.
Yeah, totally agreed. And really understanding best practices and patterns of when you might need to or want to use state proofs, what makes the most sense. Like you said, what's economically feasible at all. It'll be interesting as we sort of start to see how people use state proofs.
I mean, I see, for instance, if you're doing transactions, like global transactions, where you have, I'm going to go back to my world of CDC, right, for a little bit. At CDC, some of the most important things and most sensitive things are information about, for instance, movement of pathogen. For instance, if you manage to find some kind of anthrax, in Arizona, as an example, this is a real scenario, that's why it comes to my mind. And then you had to securely bring that back into the CDC headquarters using couriers and third parties, here in Atlanta. Well, every one of those handoffs is incredibly important. So you want to have all kinds of state proofs at that level for every transaction, digitally tied to barcodes, et cetera. So for that, you'd be willing to pay, you'd be willing to pay whatever is the going rate, because it's such an important transaction.
Totally makes sense. We have a few more questions here. I know we're over on time, but a lot of people have continued to remain on the webinar. So I think we could just keep going and answering a few more here. Let's see. So in regards to the partnership with Cloverfield, is there sort of interoperability, or what does that partnership look like? I think someone had seen that on one of the slides that you presented. It was Infor and Cloverfield.
Ken, is that for you?
I think that was on your side.
Yeah. So yeah, technically speaking, with all of our partnerships, we're very, very strongly pushing for API-based interactions, right? You know, and that's where we're going. And it's largely, whether it's, you know, Cloverfield or any other like partner, like point and click for lab information services, or even Mayo itself, Mayo Clinic, Dev Services, is really to go down the FHIR interoperability. That's where we want to be, or API interoperability if it's not a FHIR transaction. There's some cases where we do have some, I guess, in particular lab services where we have to interact at a different, like with older technologies such as HL7 2.3 kind of edition. In that case, what we're doing is really transforming the native format, like for instance, the HL7 pipe delimited text files using a transformation engine into FHIR. So, but really we're trying to very, very kind of consistently push API-based interaction. That's kind of where we're going with almost every partner.
Cool. Do you have any competitors in this space, or has this been a pretty new opportunity?
Well, I mean, there's competitors that are doing pieces of it, right? So, you know, in pretty much all of the areas, but nobody's really strung it all together. And I think that's sort of the uniqueness, you know, of what we can do to help sort of evolve what's possible with connected care. You know, there are different people that are coming out with, you know, there's a few different groups that are looking at doing specifically the kind of digital passport or health status access control, but they're approaching it from different angles, and none of them seem to have the actual technology, you know, working to pull it off. I mean, there's a lot of talk about how that could work, or that we're setting standards, or we're going to do it. But our hope is that we'll be able to sort of pull all of those groups together, you know, under this platform, and make it open, as Jim put it, so that the API can be used at a reasonable cost in a very easy, efficient way, and plugged into different types of, you know, use cases, or, you know, other companies that would want to use it as part of their applications. So we're working closely with PathCheck. We haven't sort of announced that partnership yet, but they were spun out of MIT, and they're kind of become the sort of de facto sort of technology solutions provider for the states using their GAIN entitlements, their Google, Apple contact tracing and exposure notification engine. So we're, you know, working with them, and they have a real interest in kind of the higher level version of this, and creating sort of this almost Twilio of health status, or record sort of access or locator type thing. So those conversations kind of started with COVID and now have evolved to something much bigger. But what we see is kind of doing what you guys did there at Hedera, which is kind of creating a governance committee that oversaw this. So we ultimately would open source this and use it, you know, have it be something that we helped create and that we use, but not that's under our control. We believe that the system that we kind of envision, you know, should be a public utility, and, you know, sort of controlled by the people contributing to it and using it. And that's sort of the direction that we're going towards, and or see it going. And, you know, we're in a lot of ways using kind of what you guys are doing with Hedera, you know, somewhat as a model of that, you know, to keep this sort of real sort of collaborative committee-based approach.
Cool. And you mentioned Apple and Google's contact tracing efforts. One of the questions that came through was around how this compares to that.
I mean, this, you know, that's all around, you know, contact tracing. Weirdly, it's all self-reported. So there's no real sort of automation. So that's originally what kind of brought us to PathCheck. You know, Dr. Halampka, who's had a platform for Mayo and on our board, and we're working with Daily, was CTO of Harvard Medical prior to this. And he's really close with the guys at the Broad, which is the collaboration between Harvard and MIT. And, he got us in with those guys. And, originally we were thinking about sort of adding their sort of tech as an SDK or a module, to our application to have this sort of optional contact tracing. Because, look, a lot of people consider it very creepy. And the challenge that they're facing now is Apple and Google had this mandate that it's one entitlement per state, and that you couldn't have it in an app that connected to like your photos or your camera or other, all these like very strict requirements. So essentially all that could be offered was this sort of watered down, state branded, fairly not great user interface, state created, government created app that like 3 people use. And, those were guys on the team that built it. Right. So, when we did our focus groups, it really came across that almost nobody was okay with downloading an app that was just solely for contact tracing. And most people considered it very creepy. Whereas there was a much higher level of acceptance for having it as just a feature that was kind of presented by the way with other things that they considered to have value, in an app. So what we're looking at doing is, getting Apple and Google to allow us to put it into an SDK that can be bundled in other apps, like our health check apps that we're building for universities like ASU, and then distribute it through other apps, but have that SDK kind of be segregated so it can't access those functions. And it's got its own set of API calls to the server. So it kind of is like one app. It's just a decentralized version of one app. So that's kind of where we're looking to take it. And obviously, what we're doing tied into the electronic health record systems benefits that contact tracing, because you then have sort of real-time auditing of that. My results come in, I was positive, it could immediately put out those notifications without any, human really involvement in the process.
Cool, that makes sense. And then is this in regards to when there's a transaction on Hedera? So this person's asking, is each step verification a transaction, or is it when the system calls out for a test kit, or maybe saying that the employee is cleared to go?
Yes. So, I mean, it's not for every single step at this stage. However, the technology that we built and those diagrams that I showed would allow us to use it pretty much anywhere we want to. It's an asynchronous call for us. So, using the asynchronous messaging architecture. However, up to now, really, it's been about what we think of as medical endpoints. So not every single step necessarily that you take within the application, but when the application, for instance, provides some kind of recommendation, some kind of like diagnosis, or gives you a result of some kind, such as you're symptomatic, in the example that Ken demonstrated. Those are like where we think it makes sense at this stage. However, I mean, honestly, we can definitely do more, and we're building a lot of new functionality, and there, we're building remote diagnostics and telehealth to physicians, and possibly prescription, things like this. So every one of those provides additional opportunities for us to do data stamping, because again, there's the app or the technology is providing essentially some kind of a medical endpoint, so some kind of a medical result or outcome. And we want to make sure that if later on there's a question of, was this legitimate? Did this really come from the system? What was the provider actually involved in providing this telehealth consultation or the prescription or whatever it is, that we can go back and say, look, here's the digital audit trail, and we can therefore show the authenticity of that transaction.
And so to play off of that also, one of the questions that came through is in regards to the accounts and topic IDs. Is that something that you guys would ever expose or share publicly?
That's a good question. We have not, up to now, we have not really discussed exposing that. Okay. I'd have to really think about it, Brady, on what use cases we may, and if it makes sense to do so.
Totally makes sense. Cool. Well, that it looks like that's all the questions that have come through. Appreciate you guys. I know we're over the time that we thought we would, but some of these questions were great, and appreciate you guys taking the time to answer them. I know the community really appreciates hearing from you and looking at this use case. So that's all the time that we have today. Thank you everyone for joining this webinar. We really appreciate all of your community support, and looking forward to seeing what both Acoer and SafeHealth have in store for the future.
Awesome. Sounds good. Thanks for having us.
Thank you.